अस्सलाम वालेकुम। मेरा नाम डॉक्टर परवेज़ अशरफ है और आज आप से मैं बात करूँगा गर्ड के हवाले से और ख़ुसूसी तौर पे रमज़ान में गर्ड के मरीज़ों को क्या करना चाहिए। रमज़ान के हवाले से इसलिए बात कर रहा हूँ क्योंकि गर्ड का खाने पीने से भी बहुत ताल्लुक़ है और चूँकि रमज़ान में सब लोगों की डाइटरी हैबिट्स चेंज हो जाती हैं और जिस टाइप का खाना लोग खाते हैं उससे गर्ड के सिम्टम्स जो हैं वो काफ़ी ज़्यादा बढ़ सकते हैं। तो इस वजह से रमज़ान में ख़ुसूसी तौर पे ऐसे मरीज़ों को अपने डॉक्टर से मशवरा करना चाहिए कि किस किस्म का खाना उन्हें खाना चाहिए और एहतियात किस किस्म की बरतनी चाहिए। रिफ्लक्स जो है ये एक काफ़ी कॉमन सिम्टम है जो कि तकरीबन हर एक को होता है, लेकिन जिन लोगों में इसकी शिद्दत इतनी बढ़ जाती है कि उसकी वजह से इसकी कॉम्प्लिकेशन स्टार्ट हो जाती हैं, तो ऐसे मरीज़ों को कहा जाता है कि इनको गर्ड है, विच मीन्स दैट दे हैव अ डिज़ीज़। गर्ड एक ऐसी कंडीशन है जिसको अगर प्रॉपर्ली ट्रीट नहीं किया जाए तो इसके कॉम्प्लिकेशंस जो हैं वो काफ़ी ज़्यादा हो सकती हैं। कुछ कॉम्प्लिकेशंस इसमें काफ़ी सीरियस किस्म की भी हो सकती हैं। इसमें सबसे कॉमन कॉम्प्लिकेशन तो ये होती है कि मरीज़ को हार्ट बर्न होता है और ये हार्ट बर्न पे वो उस वक्त तवज्जो देने लगता है ख़ास तौर पे कि जबकि रात को वो सोया हुआ होता है और नींद से उसकी आँख खुल जाती है और उसके सीने में शदीद जलन हो रही थी। तो इससे ये कि पेशेंट की नींद काफ़ी ख़राब होती है और अगर एक कोई मरीज़ कोई भी शख्स अगर रात को सही नींद ना ले सके तो सुबह उठ करके एक तो उसकी तबीयत सही नहीं होती, काफ़ी चिड़चिड़ाहट होती है और वो अपने काम में सही तरह वो तवज्जो नहीं दे सकता है। और बहुत सारी स्टडीज़ हैं जिसमें क्वालिटी ऑफ लाइफ को कंपेयर किया गया है गर्ड के मरीज़ों का। तो कुछ स्टडीज़ ऐसी भी हैं जिसमें कि गर्ड के मरीज़ों की क्वालिटी ऑफ लाइफ जो है वो कार्डिक पेशेंट्स से और इन सम स्टडीज़ इवन जो साइकाट्रिक पेशेंट्स जो एंटी डिप्रेसेंट्स ले रहे हैं उनसे भी क्वालिटी ऑफ लाइफ इनकी ज़्यादा ख़राब होती है अगर इनको प्रॉपर्ली ट्रीट ना किया जाए। तो ये एक ऐसी कंडीशन है जिसको कि सीरियसली लेना चाहिए। गर्ड की बहुत सारी वजूहात होती हैं और इसमें कुछ चीज़ें तो ऐसी हैं जो कि कुदरती तौर पर एनाटॉमिकली स्टमक में कुछ डिफेक्ट्स होते हैं और जिसमें सबसे कॉमन तो ये है कि स्टमक के जो ओपनिंग होती है जहाँ वो इसोफेगस जिसको हम गैस्ट्रो इसोफेजियल जंक्शन कहते हैं वहाँ पे एक वाल्व होता है और नॉर्मली जब भी हम खाना खाते हैं तो वो वाल्व खुलता है और वो फूड बोलस जो है वो पास करके स्टमक में चला जाता है और फिर वो गैस्ट्रोइसोफेजियल जंक्शन दोबारा क्लोज़ कर जाता है और क्लोज़ करने की वजह से स्टमक कंटेंट्स जो हैं ख़ास तौर पे स्टमक जो एसिड होता है वो इसोफेगस में नहीं पहुंच पाता है। गर्ड के सिम्टम्स उसी वक्त होते हैं जब ये स्फिंक्टर जो है ये सही तरह काम ना कर रहा हो और फूड बोलस जो है जब आप खाना खाते हैं तो स्टमक के अंदर तो चला जाता है, लेकिन चूँकि ये वाल्व क्लोज़ नहीं होता है प्रॉपर्ली या इसको हम कहते हैं देयर इज़ एन इनकॉम्पिटेंट गैस्ट्रोइसोफेजियल वाल्व जो जंक्शन पे होता है, तो यही फूड बोलस जो है ये वापस एसिड के साथ रिफ्लक्स कर जाता है इनटू द लोअर एंड ऑफ द इसोफेगस और वहाँ फिर ये एसिडिटी की वजह से पेशेंट को इसोफेजाइटिस होता है विच इज़ एन इन्फ्लेमेशन ऑफ द इसोफेजियल म्यूकोजा और उसकी वजह से पेशेंट को फिर सिम्टम्स स्टार्ट हो जाते हैं। Now the type of food that you take and also the amount of food that you take can also predispose you to developing reflux. If you overeat then you are more likely to develop the symptoms of reflux. At the same time, if you take fatty or oily foods, again oily foods and fatty food they delay gastric emptying and because of that again the patient is predisposed to reflux of the stomach contents into the esophagus if the sphincter remains incompetent. There are certain drugs, particularly the cardiac medications, and there are also some antidepressants which relax the lower esophageal sphincter and they also relax the stomach muscles and therefore they delay gastric emptying and they promote reflux. But obviously cardiac medication cannot be stopped, so drug history is also important in patients who have got gastroesophageal reflux disease, and if they are taking cardiac medications then you must give them extra advice that they should take extra precautions to prevent reflux. Now If we talk about the complications of gastroesophageal reflux disease, the most common is esophagitis, which is inflammation of the lower end of the esophagus, and the symptom which this produces is heartburn. Now, if this is not treated properly, these patients will go on to develop esophageal ulcers, which is called reflux esophagitis with ulceration, and there is a classification which is called the Los Angeles classification, in which there are 4 different stages of esophagitis, and this is an endoscopic diagnosis. So you can then say that the patient has got either grade 1 or grade A esophagitis, or grade B, or grade C, or grade D, which is the worst form of esophagitis. And if these patients then start vomiting when they develop ulcer, they can also present with hematemesis, which is quite an alarming symptom, not just for the patient but also for the patient's attendants. Long-standing GERD can also give rise to Barrett's esophagus, which is a pre-malignant condition. The stratified squamous epithelium of the lower end of the esophagus is replaced by the columnar mucosa, and this is metaplastic mucosa, which is not normal, and if not treated adequately, this can in some patients progress to adenocarcinoma of the lower end of the esophagus. Rarely, again, if we do not adequately treat these patients, these development of gastroesophageal reflux with ulceration and healing, and if this cycle goes on and on, then these many patients will develop what we call a peptic stricture, which is a stricture at the lower end of the esophagus, and these patients will then present with dysphagia, and this is again an alarming symptom, and the treatment at this stage then is by dilatation of the esophagus, and these patients, once they develop strictures, will require lifelong dilatation, the interval being varying from up to 3 to 4 months or even up to 6 to 8 months. But regular dilatations will be required for almost an indefinite period in these patients. So what I'm trying to emphasize is that GERD, once diagnosed, patients should be adequately counseled, and they should adhere not only to a diet but to proper medication. Now, talking about the medication, patients can be treated with different kinds of medications. The commonest is antacids. Now, those patients who just have reflux, they can be quite adequately managed just with antacids. But patients who develop reflux disease and the complications, then antacids on their own are not sufficient to control symptoms. In these patients, then we either have to prescribe the H2 blockers or the proton pump inhibitors. Now, the first line treatment is with proton pump inhibitors, because currently these are the most powerful acid suppressing drugs, and because the symptoms in GERD are mostly or mainly caused by acid reflux into the lower end of the esophagus, so any drug that will suppress acid secretion will be effective in GERD, and the more effective the drug is in suppressing acid secretion, the more effective this drug will be. And because currently available PPIs are the most powerful suppressors of acid secretion, therefore they remain the first line drugs in the treatment of patients who've got gastroesophageal reflux disease. Now, treatment, as I said, in gastroesophageal reflux disease is indefinite, because in most patients this is an anatomical defect and this cannot be corrected by medication. So patients need to take medicines indefinitely. But what you should emphasize to the patient is that the amount of medication the patient will need to take and the frequency largely depends on how well the patient adheres to the diet and adheres to the advice that the doctor gives. Now, some of the lifestyle modifications that the patient can adopt can lead to a reduction in the amount of and the frequency in the amount of medication that the patient will take. And amongst these, the most common is reducing the amount of food that you take. Instead of taking full meals, if you take small meals and more frequently and don't fill the stomach or over distend the stomach with meals, this can cause a significant reduction in the amount of reflux and the symptoms that the patient will get. We know that obesity predisposes to reflux disease. Obviously, patient cannot lose weight overnight, but you can tell the patient to adhere to a diet that will reduce over a period of time the patient's weight. So this is another thing that can be done. The other thing is, as I said, avoidance of oily and fatty meals. And when I talk about these meals, that these are the type of foods that we consume more in Ramzan. And both during Sahri and also during Iftar, people like to take full meals, and then they like to take oily and fatty meals as well. So that is why during Ramzan, patients will who have got gastroesophageal reflux disease will notice that the symptoms, they aggravate. So in Ramzan, we should advise patients to try to avoid fatty meals, but if they cannot avoid these, because a lot of people think that taking this kind of food is essential in Ramzan, or they feel that they are not fasting properly if they do not take this kind of a food. So then in these patients, then we must advise them to adhere to their medication. We might need to increase the dose of their, not only the PPIs, but as rescue medication or as an adjunctive medication, we may need to add prokinetics or even antacids, or a small dose of an H2 blocker as well, if we need to adequately control the symptoms. Another lifestyle modification is that if we ask the patient to go to bed, not to go to bed at least for 2 to 3 hours after taking a meal. If that is not possible, then we must ask the patient to raise the head end of the bed, or to sleep on at least 2 pillows. So that will also reduce the amount of reflux that the patient will get. Finally, the message that I would like to convey is that Ramzan is the time of the year when we all like to fast. From our religious point of view also, we have been ordered to fast by the Almighty. So what we can do to lead a healthy life and to not need to see the doctor frequently is to visit a doctor before Ramzan or in the early part of Ramzan and find out how they can modify their medication and what sort of a diet they should try to adhere to remain symptom-free in Ramzan and to have a healthy Ramzan, and that they may be able to fast properly. Thank you very much.